Good evening, folks, and welcome to tonight's Men's Health webinar. Tonight, we have the pleasure of hearing from Dr. Etai Goldenberg. Not only is he a urologist, he is a men's health specialist and an expert in treating several men's health conditions. He works for the Urology of St. Louis and serves men in both Missouri and Illinois for their men's health conditions. Tonight, he's going to talk about the signs, symptoms, and treatment options for ED, erectile dysfunction, and male stress urinary incontinence. I encourage you to ask questions anytime during the presentation. Dr. Goldenberg will answer those questions at the conclusion of the PowerPoint that he goes through here. In order to ask questions, tap your screen on your mobile device, move your mouse, and a toolbar will pop up on your Zoom screen. You'll see an icon that says chat. Click or tap on that, type your question in, hit submit, and then again, we will answer those questions at the conclusion of the webinar. So without further delay, I would like to introduce Dr. Etai Goldenberg.
Mike, thank you so much for the introduction. Thank you all for attending. Appreciate you guys logging in and listening. This is the desire for this talk is to really to answer any questions. So as Mike said, please put anything in the chat and we'll make sure to get to it. I have a couple spots as we go through the presentation to make sure to pause and answer any questions in the chat. Here's me looking much younger in that photo, but my name is Etai Goldenberg. I'm one of the urologists here at Urology of St. Louis. We're the biggest urology group in private practice in the metro area. We have 11 offices in both Missouri and in Illinois. I see patients in our Walker Medical building over in St. Louis and at Anderson Hospital in Illinois. I did my training at WashU in St. Louis. And then after I finished my urology training there, I went to New York and did a fellowship training in men's health, specializing in male fertility and male sexual function. I'd really dedicate my practice to taking care of men, especially men with sexual issues and fertility issues and incontinence issues. And so my desire is really to take care of men with these problems and hopefully answer any of your questions and guide you in the reason that you logged into this presentation. So the way I have this set up is that we're going to do it in two parts. I'm going to start first talking about stress incontinence, and then I'll talk secondly about erectile dysfunction. So to start talking about stress incontinence, what is it, who has it, and what are the causes? So when you make urine, not pictured up here on this slide here are the kidneys make urine. The urine then drains into the bladder then fills. When the bladder fills, the bladder is an elastic muscle. So the bladder should stretch and allow the urine to hold until it's time to urinate. That's when the bladder squeezes and lets the urine run through. The urine then runs through the urethra that's pictured here. The urethra is the tube that you pee through. Things that stop your urine from continuously leaking out are the prostate sits here with a muscle that stops the urinary flow, and this muscle group here, which is the external sphincter. Those muscles are collapsed and really holding the urine in until your urethra relaxes and allows the urine to go through. So that for that reason, when a man coughs or sneezes or lifts something heavy and abdominal pressure is there pushing down on the bladder, urine doesn't normally leak through because you're protected by the muscle group inside the prostate and the muscle group inside that external sphincter. What can cause a man to have leakage? So one type of leakage is what we call stress incontinence, where that stress, that abdominal pressure pushes on the bladder and then the urine leaks through past those muscle units. Another type of incontinence or leakage is when a man has urge incontinence. That means their bladder squeezes more often or more strongly than you'd want not because you want it to squeeze, just because it squeezes on its own. That's that gotta go and I can't hold my urine feeling. And some men have a combination of both of those issues. The most common reason why a man would have stress incontinence again is when you cough, sneeze, lift something heavy, and that muscle unit doesn't stop the urinary flow, is because you lost some of that muscle unit. The muscle inside the prostate is about half of that continence mechanism. And when you remove the prostate because of either prostate enlargement, or most commonly because of prostate cancer surgery, you're really relying only on that sphincter muscle to provide you with protection from leakage. So in men that have their prostate removed for prostate cancer, it's about 10% of guys that have long-term leakage after their prostate's removed that require some intervention. Why does that happen? So if you look here, this is a diagram of the internal anatomy, the bladder sitting here, the prostate here, and the urethra here. This is a man lying on his back compared to the picture before with someone standing up. When the prostate's removed, an incision is made here and here, where the prostate is then removed usually for prostate cancer, and then the urethra is then sewed back together to the bladder. And you see you're relying only on the sphincter muscle that was beyond that in order to protect from leakage. So like I said, about 10% of guys, 9 to 16%, will have long-term leakage from coughing, sneezing, doing movements because they're relying only on that sphincter muscle that's here. Excuse me. So what are the options that a man has if they have this type of leakage? One is behavioral modifications. If you know that you leak when your bladder is more full, before you go hit a golf ball, before you're more active, you plan to make sure your bladder is as empty as possible. So you go more often, you go at planned times. Other ways are non-surgical options are physical therapy or biofeedback or Kegel exercises. These are ways that you can help strengthen the muscles that are in the pelvic area, in that urethral area, and strengthening those muscles should allow for some regaining of that muscle control. And coping mechanisms like pads or diapers or catheters are ways to collect the urine in case those things don't work. If a man has leakage that's persistent, they still have leakage for over a year after their surgery, and it's bothersome to them, then we usually can talk to them about the options of surgical intervention to hopefully give a long-term fix for their leakage. There's two types of leakage, two types of surgeries that are available for men that have leakage from stress incontinence, most commonly, like I mentioned, after prostate surgery. One is called a male sling. A male sling is a piece of mesh that's placed under the urethra and gives the urethra extra support, really positioning that residual muscle, the muscle that's left over after the prostate was removed, to give it more of a backboard or support so that when you cough or sneeze or lift something heavy, that muscle is positioned in a way that can work better. People that either have severe leakage or don't have enough muscle that a sling would be sufficient, or they had a sling and it didn't work well enough, can have what's called an artificial urinary sphincter. This is a mechanism with a cuff that goes around the urethra and holds pressure the way that the muscle does previously, holding that pressure at all times until you squeeze a button that allows the urine to flow. So taking a little bit more in-depth look on these surgical options for men with stress incontinence, one is this male sling. If you look here, this diagram here inside the circle shows that blue area is the muscle that's left behind, that external sphincter. When you put this piece of mesh here on the outside of the urethra, and then you lift it up, and by lifting it up, that folds over itself and makes that blue line longer, giving that sphincter extra support. That mesh then runs here under the urethra and then loops through the obturator canal, which is part of the bones in the hip, and secures that into place. That acts as a hammock and gives extra support to the urethra, so that way when you cough or sneeze or lift something heavy or hit a golf ball, that muscle is more expanded and has more support. This is really best for guys what we call mild to moderate incontinence. So if you leak somewhere between 1 and 3 pads per day, it really does give you long-term success. My goal is to have my patients leak 1 pad or less after the surgery. Over 90% of patients would have it again and would recommend the procedure to a friend. It's what we consider an outpatient procedure. I do have some of my patients that will do the procedure and go home the same day, and I do have some patients that stay overnight and then go home the next day. It's probably about a 50-50 split. What's nice about the device is once that mesh is inside and it supports and works well, that you don't have to interact with the device. The sling just really sits there and allows that muscle to work better. The other option is an artificial urinary sphincter. This is pictured here is this cuff that goes around the urethra and surrounds the urethra, putting kind of this permanent pressure on the urethra until you squeeze the control pump. Squeezing the control pump takes that area that's closed like this and opens it up, lets the urine run through. It runs for about 2 minutes or so, and then the bladder gets emptied, and then you get to pee again. This does require interaction. You have to squeeze the pump every time you pee for the rest of your life. That said, this is really a great option for guys with either moderate or severe or significant other reasons why they can't have a sling and really restore their continence. In my practice, these are my happiest patients, guys that are leaking 6 or 7 diapers per day, and we put a cuff in like this. They recover from the procedure. It takes about 6 weeks after the surgery until we can turn the device on. Once we turn the device on, it immediately gives them back their continence so they really don't leak. And the goal, again, is to leak 1 pad or less per day. Here's an animation, hopefully describing what I already did. That here is this control pump in the scrotum. You squeeze that and it allows that cuff to open. The urine can then run through the cuff. Over the course of about 2 minutes or so, the cuff then slowly closes down. Again, putting pressure on the urethra so that the urine won't leak through it anymore and letting you be dry until the next time you push the button. Again, this is a very highly satisfactory procedure, 90 to 95% satisfaction rate. This is really designed for men with either weaker sphincter muscle. So if you don't have enough muscle that the sling will support it, this really is for guys that either they don't have that muscle or they've had other factors like radiation therapy that may have also damaged that muscle unit. Like any procedure, there is risk. So if we put in a sling or an artificial sphincter, we worry about most is infection. Before, during, and after surgery, we give antibiotics. We put special washes on the skin in order to reduce that risk of infection, but there is still that risk. When we put in a sling, we do put the device in and we tighten the urethra, hopefully to a point where you have control, but it's not too tight or too loose. But there is a risk of either making that device tight where you need a catheter for some time after the procedure, or too loose where you still have some leakage after the procedure. With an artificial sphincter, because it's a more complicated mechanism, there is a risk of malfunction or failure at some point. The average device lasts somewhere about 10 to 15 years. Because of the constant pressure on the urethra, there is a risk of erosion or injury to the urethra itself. And again, if we put the cuff too tight, there is a possibility of retention and requiring a catheter for some period of time after the procedure. Because these devices and slings are really designed for men that have leakage after some type of prostate cancer intervention, they are usually covered by insurance. I think we've had really nice coverage. Medicare and most other private payers do pay for male continence surgeries. That said, before we do the surgery, we make sure that you are evaluated by by our team. We work together with Boston Scientific to make sure that you know whatever out-of-pocket expenses you would have before you move ahead with the surgery. I hope that gave a nice overview of these options. If you do have more questions, there's fixincontinence.com that can hopefully help you answer more questions about incontinence after prostate cancer surgeries. And then I'm happy to see you in an appointment in order to take the next steps. So someone like me who does a lot of prosthetics is someone that you'd like to see. I have a couple of my partners, and there's a couple other people kind of in the St. Louis community that do a fair number of these artificial sphincters and slings. If you're having that issue, I think it's important to talk to someone who does a fair amount of these incontinence procedures because it's not the most common urology procedure, and you really want someone that has an expertise in it. That said, if you're being treated for prostate cancer, especially if you're someone already in my group, I think it's important to just mention this to the doctor you're already seeing. They may have some tricks or some other therapies, or they may say, why don't you try physical therapy again? And if that doesn't work, then move ahead with talking about one of these operations. So overall, male stress incontinence is a really known side effect of prostate cancer treatment. Like I said, 1 in 10 men who have their prostate removed do have long-term leakage. And then there are coping strategies and other options that are available. But for a man that has long-term leakage, a permanent solution with either a sling or an artificial sphincter is a nice option if that's something you are interested in. Mike, Do you have questions in that chat before I move on to the second half of the chat?
We do. So there's a question about UroLift and if that intervention can increase or alter continence.
So UroLift is a procedure for people that don't know that small little tabs are placed in the prostate, pushing the prostate open to give a better flow of urine. That's a procedure that's approved for men with an enlarged prostate. There is really minimal to no risk of having incontinence because of a UroLift. A little different than some of the other procedures like a TURP or a resection with either a laser or with removal of the prostate that has about a 0.5 to 1% chance of having this type of stress incontinence. The UroLift is nice because that risk of incontinence is really should be zero. That said, if you do have incontinence, UroLift really isn't designed to help that type of leakage. The UroLift is really more designed to help you, by pushing the prostate open, get a better urinary flow.
So there's a question, thank you for answering that, about the cuff, specific to the AUS, and if that could potentially impact sexual function.
So the artificial urinary sphincter cuff just goes around the urethra itself. When it's placed, it should not affect sexual function. That said, depending on what your preoperative sexual function is, sometimes we'll put the cuff in a way that may impact sexual function. So it's really important to talk to your provider before you proceed with that surgery about what your sexual function is beforehand. I do have plenty of patients that I take care of that have leakage as well as erectile dysfunction, and sometimes we will do a procedure for incontinence and do a procedure for erectile dysfunction with a penile implant at the same time. But yeah, there is a chance of affecting erections with an artificial sphincter, especially if you do what's called a transcorporal cuff. And so really important to kind of talk to your doctor about where you stand in terms of erectile dysfunction before you move ahead with the incontinence surgery.
Thank you. There's a question about the location of the pump. Is it inside or outside of the scrotum?
So the pump is in the scrotum. So the scrotum is the skin on the outside. So it's not inside, or it does not replace the testicles, but it is in the in the skin, in the subcutaneous tissue you can feel it in the skin, but it's not adjacent. It's not connected to any of the organs. It's hidden inside the body.
Thank you. And there are no further questions at this time.
All right. And then I have a diagram. When I move on to this, that should be very similar. Hopefully, we'll answer some questions about the artificial sphincter pump. All right, I will continue on then. Am I doing okay on time? Okay. So the next thing I want to talk about is erectile dysfunction and what some of the treatment options are for that. As I talked about with incontinence, I think as I talk about erectile dysfunction, I'm going to talk about who it is, who has it, what it is, and what are the causes. So when I think about erectile dysfunction, I think every person has their own interpretation of what that means for them. But my thought on erectile dysfunction, or ED, it's the persistent inability to achieve or maintain an erection that's firm enough to have sexual intercourse. And it's really, really common. Literature will say that 1 in 5 Americans, so 20% of men over the age of 20 have erectile dysfunction, and then more than half of men over the age of 40 have some degree of ED. So again, very common for men to have erectile dysfunction as they age. What does that mean in terms of this diagram of, when I think of erectile dysfunction, when a man at rest has a penis that looks like this. When I think of it, it's really 2 erectile bodies. So if you look here in the red are the tubes that are filled with blood when you have an erection. Those erectile bodies have blood vessels in them kind of waiting and have the ability to engorge when they are engaging in sexual activity. And the tube underneath is the urethra. The urethra is the tube they urinate through. So when a man wants to be engaged in sexual activity, that usually starts in their head, that usually requires stimulation and desire, being in some type of low stress environment, and also having the right amount of testosterone. Testosterone is the hormone that helps with libido and sex drive. Once that signal leaves the brain and goes down to the penis, you have to have nerves that can travel from the brain all the way down to the penis, and blood vessels inside the penis that are able to engorge the way you want to have it go from this to this. So as men age or they have developed other medical issues, it's very common to have problems in other parts of your body that can affect your erectile function. And as I talked about, it's tubes that fill with blood, and so therefore anyone with any type of vascular disorder, peripheral vascular disease, high blood pressure, high cholesterol, things that affect the blood vessels and blood flow can affect erection. In addition, diabetes can affect nerve endings and affect blood vessels. Different medications that lower or change your blood pressure very commonly will affect erections, as well as prostate treatment can be causes of erectile dysfunction. So I'm going to talk about each of those in a little bit more detail. So diabetes is very common. About 15 million men in the United States have diabetes. And we found that men with diabetes are affected by erectile dysfunction at a younger age, about 10 to 15 years younger than men without diabetes. And those men have more trouble getting treatment because the most common treatments for erectile dysfunction, like pills, really don't work as well for men with diabetes as they do in the general population. For a man with diabetes, the amount of time they've had diabetes, how well they've controlled their diabetes, the presence of other issues with diabetes like neuropathy in their fingers or their toes really can be precursors of having erectile dysfunction. In terms of heart disease, like I mentioned before, the way the penis fills with blood, there's a penile artery, which is the one blood vessel that brings blood into the penis, and there's one per each side of those two tubes inside the erectile bodies. Those blood vessels are very, very small. That penile artery is about 1 to 2 millimeters in size. You compare that to the heart arteries or the coronary arteries, they're 3 to 4 millimeters in size. So any patient that tells me that they have a history of heart disease, they have a history of coronary stenting, that tells me that I know inside their body they had blood vessels about this size, 3 to 4 millimeters in size, that became blocked up or occluded and needed help. If you have blood vessels this size that got blocked up, it's very likely that your penile arteries, these much smaller arteries, have a chance of having blockage and not having as much blood flowing through them as they used to. How do you reduce your risk of heart disease and having erectile dysfunction due to heart disease? It's really the same things that I think most people's primary care doctors will recommend for them to help with their heart disease, including diet, exercise, weight loss, not smoking, and trying to reduce your stress. Low testosterone. So testosterone is a hormone that's produced by the testicles. The testicles really have two jobs. One is to make testosterone, which is the hormone I'm going to discuss, and then they make sperm. As men age, they make less testosterone. And about 4 in 10 men over the age of 45 do have low testosterone. Oftentimes, men with low testosterone also have other risk factors of erectile dysfunction, including being overweight or having diabetes or having high cholesterol or having high blood pressure, things I mentioned before that can also cause issues with blood flow. And so one of the first things I'll check in a man that comes in with erectile dysfunction is check their testosterone. We check testosterone in a morning blood test before 10 a.m. You have to have a blood testosterone level above 300 is considered normal. So if you're below 300, that'd be considered a low testosterone level. Men with a low testosterone sometimes have no problems or no symptoms at all and didn't know they had it, or the only issue they have is erectile dysfunction. But other issues can also be fatigue, so feeling run down and tired, having poor concentration, having memory issues, overall just feeling kind of worn out and tired. If you have low testosterone, like I said, there's 2 blood tests that show a low testosterone level. There are options for treatment. Those include giving medicines that you will raise the amount of testosterone, this hormone that goes in your bloodstream. There's gels that you can put on the skin that absorbs testosterone. There's injections that most men will do weekly. There's also some new pills that are FDA approved that you can take twice a day to raise your testosterone levels. Now, treating your testosterone does not guarantee that you'll return erectile dysfunction, even though I do have many patients that it does help. but it has been shown to help the response that you have to other types of erectile dysfunction treatments. In terms of prostate cancer, you should have seen this picture before when I was talking about urinary leakage. The prostatectomy is the surgery where we do is there's cancer that's found inside the prostate, and therefore the prostate is removed by making an incision above and below the prostate and bringing the urethra into the bladder. When this is done, most times we do what's called a nerve-sparing prostatectomy. That means the nerves that run here on either side of the prostate are gently moved off the prostate and then preserved, as you see here. Those are the nerve endings that go from the rest of your body into the penis. Now, oftentimes, just the sheer movement of those nerves off of the prostate can cause a temporary loss of ability to get an erection. But in many men, that is a long-term problem where that nerves never recover from being removed off the prostate and have a long-term erectile dysfunction. And the literature says about half of men that are treated for prostate cancer do have erectile dysfunction. It's probably one of the most common reasons I'll see a man in my office for erectile dysfunction is because of treatment because of prostate cancer. Peyronie's disease. So Peyronie's disease is a plaque formation or scar formation in the penis that causes most commonly penile curvature. So as you see in the picture here, this plaque forms most commonly on the top of the penis, but can be anywhere around the penis. Like I mentioned, when I think of the penile anatomy, it's the two erectile bodies or these cylinders that fill with blood when you get an erection. If you have this plaque that's less elastic than the rest of the penis, when you get an erection, everything else stretches nicely, but that plaque doesn't stretch, and therefore you get curvature in the direction of the plaque. This can cause pain for the man with sexual activity, pain for his sexual partner, can also cause just the inability to have penetration due to that curvature. There are several treatments for Peyronie's disease, including different types of stretching or modeling exercises. There's one FDA-approved medicine for Peyronie's disease. This is a medicine called Xiaflex. Xiaflex is an injection into the plaque itself to help degrade or break that plaque down. In addition, surgery can be performed for men with penile curvature because of Peyronie's, including a plication procedure where we put sutures on the opposite side of the curvature in order to straighten the erection, cutting or removing the plaque out, or penile implant surgery, which is a really nice option for guys that have curvature and erection issues. So I tried to go quickly through the different medical conditions that can cause erection issues. But now kind of any man that really gets to this point where they say, all right, I have erectile dysfunction because of any of those issues or something else that I didn't mention, I want to talk to you about what your treatment options are. As I get into that, I think that this is something that because of the prevalence, how common erectile dysfunction is, more and more primary care doctors and general urologists really have become more comfortable talking about a lot of these issues about starting the conversation with erectile dysfunction. So I think it's reasonable to start this conversation with your primary care or if you have a urologist that you're already established with. Prosthetic urologist, someone like me or some of my partners that really focus in erectile dysfunction specifically, can talk to you about some of the surgical options that we can talk about, which I'll get to in a moment. So here's my really overview about what the treatment options are for erectile dysfunction. Those include pills, wave therapy, injection therapy, suppositories or small pellets into the urethra, vacuum erection device, and then penile implant surgery. So to start off, pills, things like PDE5 inhibitors, these are things like Viagra and Cialis are the most common medications that are given really when a man starts off saying they have erectile dysfunction. The way this medication works is that it allows the blood to flow and stay inside the penis better than when that medicine's not in the system. Viagra and Cialis and these other medications, they don't give a man an erection, but they allow those blood vessels to be more excitable. So when you are engaging in sexual activity, should allow for a better and a stronger erection. Viagra and Levitra, some of these medicines are more affected by food. Cialis is a bit less affected by food and stays in your system a little bit longer. I do have some men that have a better response to one medication versus the other. How effective are they? Somewhere around 70% of guys get a good response to them, and a little bit less for men with either diabetes or that had prostate cancer surgery. What are the common side effects? So oftentimes men will say that I have a flushing or a headache or a stuffy nose. If you have those issues when you take the medicine and it's not bothersome to you, really not an issue. However, the medicines also can cause a drop in your blood pressure, especially if you're taking something like a nitrate or nitroglycerin, and that'd be a reason not to take a medicine like this. Shockwave therapy or low intense shockwave therapy is something that really has gotten more traction recently, and it's really more commonly advertised. This is a non-FDA approved option to help men with erectile dysfunction. This is really a good option for guys with mild to moderate erectile dysfunction. The way this therapy works is these small pulse waves that go to the penis and really kind of irritate, and the idea is they irritate and bother the blood vessels that are in the penis. The thought being that mechanism and that small shock wave to the blood vessels allow those blood vessels to be more expandable, and therefore allow those blood vessels to function better and expand more, and hopefully also allow newer blood vessels, or we call it neovascularization, inside the penis to allow those blood vessels to work better, delivering blood into the penis. The way it's done, it's usually a procedure that you come into the office on multiple occasions. The way we do it in our office is you come on 6 separate occasions to the office. You have the therapy for about 20 to 30 minutes. And the hope is that with time, after those 6 therapies, that you should have improvement of blood flow into the penis. The average patient, I find, has somewhere about 20 or 30% improvement of their overall erectile function. And so in my thought process, it's someone that has mild to moderate erectile dysfunction, where they're taking medication like a Viagra, Cialis that's not working as well, or they don't want to try that medicine, they'd like to try something that doesn't require medicine. I think that's really the best patients for the shockwave therapy. Men with really severe erectile dysfunction, men with nerve issues that are causing the erectile dysfunction tend not to do as well with this type of therapy. That said, like I said, it's an off-label, non-FDA approach, but it is considered very safe. A vacuum erection device. This is a device that looks like this. It's a cylinder that goes over the penis. It's hollow and it goes against your body. You either press a button as shown here in the picture or pull a lever in order to pull the air and form a vacuum inside that tube. By forming this vacuum or negative pressure space, the blood is then promoted to pull into the penis. Once the penis is full inside the cylinder, you push a ring off the tube onto the base of the penis to allow the blood to then stay inside the penis. This therefore allows you to preserve or maintain your erection, and you keep your erection while you have that band on the base of the penis until you take it off. You need to maintain that band during sexual activity to maintain the erection. Satisfaction rate varies somewhere to 60-70% of guys are happy with it. What's the issues with the vacuum device? It can be uncomfortable. There can be some bruising associated with it. Some men say that they don't enjoy sexual activity because they lose some feeling or the penis feels cold. And those are probably the most common reasons why a man would not use the device in the long term. A urethral suppository is probably one of the least common treatments that we'll use for erectile dysfunction because it is maybe a little bit less effective and rather uncomfortable. But the way it works is it's a medicine that needs to be refrigerated. It then has this applicator or apparatus that deposits a small pellet into the urethra. Once it gets into the urethra, the urinary tube, it gets dissolved and then absorbed by the erectile bodies. About half of men don't continue use because of either discomfort from placing the device or lack of efficacy. The biggest risk that we worry about with this is because the suppository kind of melts inside the urethra and it gets absorbed by the erectile body. It's also absorbed by some of the surrounding blood vessels. Sometimes it can cause blood to pool in the pelvic area and you can get lightheaded or dizzy. And so I tend to have my patients come in the first time and do that suppository in the office just to make sure that you don't get lightheaded or dizzy or a drop in your blood pressure when you're learning how to use it, and that way you're comfortable with it. Injection therapy. is actually the same medication that we use in those suppositories, but instead of having it just absorbed inside the urinary tube, it's injected directly into the erectile body, into the penis itself. I like this option a lot because it really delivers all the medicine exactly where you want it. Usually within 5 to 10 minutes after the injection, you get an erection. The goal is the erection to last about half an hour to 45 minutes. And does work really well. When a man's interested in learning how to do these injection therapy, I usually have them come to my office. We then teach them how to do the injections. And once you're comfortable with doing the injections yourself, we give you a prescription. The medicine needs to be refrigerated between uses. You give yourself a shot and then can engage in sexual activity. Most common side effects, there is some pain associated with the needle. The reason I have men come to the office for their original teaching is sometimes this medicine works so well, you get a prolonged erection or a priapism. And so I like to be on hand the first time you do an injection to make sure you're comfortable with that, make sure we give you the appropriate dose. And the odds of my patients having a problem once they're comfortable and know how to give themselves the injections is really low. And then I want to talk about a penile implant. A penile implant is a surgical procedure. The way this works is we replace those inner cylinders or inner tubes inside the penis with cylinders that are filled with saline or salt water. They're then controlled by a pump that sits inside the scrotum. And then there's a reservoir usually in the low abdomen that holds the saline or salt water between uses. When you want erection, you squeeze this pump that sits here inside the scrotum. And when you want the erection to go down, you press a release button, the erection goes down. Somewhere between 90 to 95% of men are happy that they have this device placed. It is a surgical procedure, so there is potential risk, including infection or mechanical problems, or the device not sitting or working the way you want it to. But again, very highly satisfied. Very high satisfaction rate for patients and for their sexual partners. There's different types of implants. Like I said, the most common implant we do is this AMS 700 device. It's the cylinders that are in the penis, the pump in the scrotum, and this reservoir in the low abdomen. But there are other types, a two-piece device, which is without the reservoir in the abdomen, or what's called a spectra or concealable device that you can just bend up and bend down that always stays rigid. One of the reasons I like the AMS 700 device the most is that I think it mimics the normal function of the penis more than any of the others, because it really allows for the penis to completely decompress to a flaccid state, and those two cylinders can get very rigid and allow for what works and feels like a natural erection. But in addition, the device, when we implant it, comes coated in antibiotics. That antibiotic coating significantly reduces the risk of getting an infection with this surgery. Here's a little animation, which hopefully will help explain what I'm talking about here. If you see here, the pump sits inside the scrotum, similar to the artificial urinary sphincter control button. You squeeze and you're shifting the fluid from that reservoir into the cylinders. When you let go, the fluid then stays inside the penis until you press the release button. And then at that point, then the erection goes away. Lucky to have a patient here that allowed us to video him inflating and deflating his device. Oops. So if you see here, in the flaccid state, you really wouldn't know that there's something in there. You then pull the pump up inside the skin. You can see this man is squeezing the pump here with his right hand and holding it steady with his left hand. As you're squeezing the pump, the cylinders inside the penis are then filling with that saline that's moved from the abdomen into the cylinders. You can see the pump is here. The erection does look natural. And there's nothing outside the body. And then what you do is then you pull the pump up to the skin, and so you can feel it. You press the little release button. Right there is that button there, and he just hit with his index finger. By pushing the button, then the fluid then does go back into the reservoir. And then oftentimes my patients will then squeeze the penis in order to allow all the fluid to then leave the penis and go back into the reservoir until next use. Again, very highly satisfactory surgery, where over 90 to 95% of guys and over 90 to 95% of their partners were happy with the device. But again, there is risk. Anytime we do a surgery, there's a risk of infection, there's a risk of bleeding, there's a possibility of erosion or injury. And so we really talk about all these things that happen rarely with you before surgery, so you really know kind of what all the pros and cons are before we proceed. Penile implant surgery is designed to be a permanent solution for erectile dysfunction. It's spontaneous and it's hidden inside the body. Over 500,000 of these devices have been placed. It is often covered by insurance, but not always. And so we do verify with your insurance provider before we move ahead with the surgery. And Boston Scientific does a really nice job of helping us, making sure that we kind of dot all the I's and cross all the T's to make sure that we know what your out-of-pocket expense would be if you desire to have this procedure. And so really, in summary, erectile dysfunction is really common. There's really not one solution for everyone on this chat, whoever is logged in. I'm sure that different parts of this appeal to different people. If this is why you tuned in for erectile dysfunction, I think it's important to talk to your provider, talk to your partner, and really taking this first step and knowing what's out there, and then deciding on how you like to proceed. So here's lots of disclaimers. And I'm really lucky here to have Cliff. Cliff, you're still there, right? I didn't put you to sleep.
I'm still here.
Perfect. So Cliff is here. He's going to talk about his experience. I'm super lucky to have him as an advocate and really give his perspective.
Well, good evening, everyone. What you're going to hear about is the journey that I took with my wife from the time I had prostate cancer and ended up with ED and had it resolved. When I was 58, I was diagnosed with prostate cancer, and at that point decided to have my prostate removed. After I had my prostate removed, I ended up with erectile dysfunction. Went back to my regular doc, and they did put me on Viagra. Unfortunately, Viagra and the Cialis and the Levitra all gave me terrible, terrible headaches, and I just couldn't function with it. So I went back to him and asked him what else was available. And he said, well, the only other thing he knew about was the vacuum erection device. So we bought one, and yes, it works. Unfortunately, it is not spontaneous. And it seems that the more excited you are, the longer it takes to get the thing working and getting that rubber band basically on the base of the penis to keep the blood in. Penis does get cold, does get a little blue. It is not very appetizing looking for your partner. And the reality also was that taking off, taking off the band actually was no problem getting up the shaft, but going over the head of the penis, it hurts. So I did away with that after a few months, and then basically went into a major depression because at this point I had lost my manhood. Didn't know what else to do. Luckily, this was way before the COVID. I was invited to a seminar like this in person, and I learned about the other devices, the little pills, the Muse pills that go in the head of the penis, the injections, and the implants. I wasn't too thrilled about the pills, the little Muse pills. I was less thrilled about the injections. And my wife and I decided that the implant was the best possible recovery device to use. So the day after my 60th birthday, I had the implant done. It took me about 2 weeks to be back to normal, go back to work. I went back to the doctor after the third week. They showed me how to use the implant. I used it for a week, waited, and then at the 6th week, we started to have intercourse again and realized at that point how much intimacy we had lost. And it was back, and that was great. The implant that I had first lasted 14 years. So I was 74 when it stopped working, and I had a revision done. I had another implant put in, and I'm happy to say that one works absolutely just as well as the first one. It gives you a very, very rigid, solid erection for any type of intercourse you would like to have. I would say a couple things that people ask me. One of the best things they ask me is, what happens when you go through the airport metal detector? Nothing. It doesn't do anything. It doesn't go off. Then they ask me, okay, well, I have artificial knees and it goes off. So they take this wand and they wand me up and down my body and on the inside of my thighs and around my crotch. And again, nothing. It just doesn't respond to anything. So basically you have an ability to have an erection anytime you want without having to worry about injections or pills or keeping things in the refrigerator. It's very, very handy. Another thing people ask me is, does it stop you from getting anything done for scans like PET scans or MRIs? The answer is no, doesn't do anything there. And the last thing they ask me is, well, what happens if you have a bladder infection? Something like that. Does that create any problems for you with, with the implant? And the answer is absolutely not. It has no effect whatsoever on the bladder. Like I said, at 6 weeks, we went back to having intercourse. And at 6 weeks, I also went back to the gym and started working out with my friends again, showered with my friends. They have absolutely no idea there's anything inside me because it is just there and it's nothing shows. The one thing I will say that I would suggest, ED is not necessarily just a male disease. I think ED is a partner's issue. And the sooner you can get your partner involved in going to the docs and learning about what the treatments are, I think the sooner you will be able to have that individual understand that it's not that you're having an affair and you don't love her anymore or whatever it is, but that it's really a medical problem and there is a solution. So Michael, I'll turn it back to you for any questions for Dr. Goldenberg or myself.
Thank you very much.
Thanks so much for sharing.
Yeah, I really appreciate you, Cliff. So a lot of questions here. Start with a couple common ones. So nitrous oxide, products like L-arginine, do you recommend any of these over-the-counter supplements to boost nitrous oxide? And do you have any just general thoughts on over-the-counter medication?
Unfortunately, there's really not been any great studies to show the pros and the cons of those over-the-counter medicines. The way that Viagra and Cialis work is they work on nitric oxide pathways in order to preserve the amount of nitric oxide that's inside the penis and allow there to be more maintenance of erectile function. The problem is that some of these nitric oxide medications maybe have Viagra or have Cialis in them. They're really not regulated in the way that, that pharmacies are regulated. And so you don't really know what you're getting in all of them. So I tend to tell my patients to try something that with a prescription for me, as opposed to something where they don't know exactly what they're getting. That said, I think the risk is relatively low. Taking those medicines, except for, I would say the caveat, if you do take nitrates or some other medicine for heart disease, making sure not to take those over the counters because you can have the same side effects that you have with, the prescribed therapies.
Thank you. Now, there's a couple questions about testosterone. How long can you take exogenous testosterone? And does taking it have a negative impact on your body? Generally, can it negatively affect your erections? And does it affect you if you stop taking it?
So testosterone is a hormone that's naturally produced by the testicles. And so the idea of testosterone replacement therapy is you're really getting your blood testosterone level to be, in the normal range. So we're really not getting guys super therapeutic. We're not turning them into, Mark McGuire or Barry Bonds. The idea is to really to allow you to be in the normal range. There are long-term studies showing that it is safe to be on testosterone. So once a man goes on testosterone, what will happen is oftentimes their testicles will stop making testosterone on their own. And so for that reason, I usually tell my patients that if they are choosing to go on testosterone replacement therapy, to expect it to be a lifelong therapy. So I think that was the first question. Was there something else I missed, Mike?
Yeah, I think just if you stop taking it, can there be negative effects?
You should expect it to be a lifelong therapy. If you stop testosterone therapy, you may go back to how you were before at a low testosterone. But that said, if you've been on it for a long period of time, what can often happen is you'll actually get yourself even lower than you were originally. So in my experience, and really according to the American Urology Association, we recommend a 3 or maybe even a 6-month trial of testosterone. If you go on a testosterone therapy and feel the same, don't get any benefits from it, I usually stop it at that point. So that way you're not negatively injuring the testicles. That way, if you didn't need it before, that you need it now. In addition, I only give testosterone to men with a low testosterone. If your testosterone is normal, I don't recommend going on testosterone replacement.
Thank you. Now, can frequent long distance bicycling, cause or exacerbate stress urinary incontinence or ED?
Long-term bike riding should not cause stress incontinence. There is, if you have injury to the urethra or injury to the perineal nerves, it can affect the urethra itself, so it can cause incontinence or scar tissue or injuries different than stress incontinence, but more from narrowing and from what's called a stricture. In addition, pressure from the seat can increase the risk of prostate irritation or can affect erections by affecting those nerves that go down to the penis and cause some sensation changes.
Thank you. There's a clarification question. So you'd mentioned that normal erections in part come from stimulation of nerves in the penis.
Mm-hmm.
Then why does removal of or disturbing the nerves when removing the prostate from prostate cancer have such an effect on getting an erection? Are the nerves connected to both? In both areas connected? Do they work together? So
there's multiple nerve endings that go to the penis. There are the nerves that run under the prostate that allow for the blood vessels, for the most part, to be dilated, and that's those neurovascular bundles that run across the prostate. There's a different pathway of nerves that actually run from the outside, not through the pelvis. That's those nerves I was talking about before with the bike riding, and those really are what gives sensation on the outside of the penis into the skin and part of the sensation.
Now, are there any?
Yeah.
I guess there's another question about nerve, just disturbing nerves in other parts of the body, like the spine. So if you impact nerve in a different part of the body, could that also affect erections?
Definitely. And everyone, depends on how that nerve is affected and depends on which nerve is affected and how severe the nerve injury is. But if you have an injury to nerve pathways anywhere along the body, so starting it from, traumatic brain injury or any type of spinal cord injury, and it depends on which level and where that injury occurred, to prostate removal that can affect nerves. All those things can affect the way the nerves function and deliver that message from the brain down to the penis, or the other direction, from the penis being stimulated back to the brain. In addition, things like diabetes that can cause neuropathies can also change the way the different nerve endings function and how you can perceive touch and be stimulated, and how that pathway from your brain down to the penis can function in order to get the blood vessels inside the penis to dilate.
I think it might be worth noting, are there any things that people can do to improve their nerve function?
So, I think, depending on what your cause is of your neuropathy or of your nerve issue, you can preserve in different ways, especially in diabetics. Good blood glucose controlled management of your diabetes is really the best way to prevent getting neuropathy or nerve problems. In terms of spinal cord issues, lifting things appropriately, not, bending with your knees and not with your back are ways to prevent causing slip discs or nerve problems in your back. But yeah, there's lots of things that can affect nerves that really are out of your control, development of nerve disorders and different types of medical conditions that affect nerves. Unfortunately, we don't always have cures for those.
Now, there are at-home wave therapy style machines and devices available. Do any of these work?
So, the problem with the wave therapies is that, the answer is, in short, we don't know, or I don't know, because even the wave therapies that I do recommend and will tell you that do have a stronger and more proven wave component that should hopefully allow blood vessels to respond better, also are not FDA approved. And so, unfortunately, it's a pretty big space in order for me to say this doesn't work and this does work, because there really aren't awesome or great studies. The studies that we do have really do favor the types of devices that that we have here in our office, which are wave therapies, which is a little bit more power that can cause these this irritation that hopefully allow for neovascularization. The studies on the less intense wave therapies that you can purchase at home or that oftentimes are provided in these men's clinics don't have that same power. They don't need medical supervision in order to be used, and therefore the thought process would be that they won't have as strong of an effect. I definitely can't say that they have no effect, because I do think that there is some potential for improvement, and we just don't have really all the data out yet in order for me to say, which therapies are the best and which protocols are the best for these wave therapy. I bet if you log into this talk 2 years from now, I may have a lot more data, because there's a lot of studies going on right now with wave therapy. But I think it's too early to tell you exactly, what works and what doesn't. I will say the device that we have here has nice data that the average guy does get about 20% improvement, but that definitely hasn't been approved for that use.
Thank you. There's a question about pills, and specifically the timing and how important that is in the effectiveness.
Yeah, so timing for pills like Viagra and Cialis and such, is very important. Viagra, Levitra are medicines that work pretty quickly. They're also really affected by food. And those medicines really work the best on an empty stomach. You want to take them in about an hour before sexual activity on an empty stomach. That allows for the medicine to get absorbed the best. Cialis is a medicine that's less affected by food and it stays in your system for about 36 hours. And so I really don't give too many food recommendations with the use of Cialis, except for that if you do take it, expect it to take longer, maybe more like an hour or two to really kick in.
So as somebody who can test if there is blockage in their coronary arteries, is there any testing to see if there's blockage in the penis vessels or arteries? And if so, is there hope that they can obtain an erection if there is blockage?
So there are tests that can be performed to look if there is a blockage in the penile arteries. That is usually a penile ultrasound or a Doppler ultrasound of the penis. That can show how much those blood vessels dilate. That's a procedure where we take some pictures of the penis, we give a small injection in order to stimulate the blood vessels to dilate. And then the ultrasound will show how much those blood vessels will increase in size with the ultrasound. That said, there aren't really any therapeutic options that are different for a man that has poor blood flow than that has normal blood flow. So really, in my experience, the options are the same for someone that has erectile dysfunction because of poor blood flow versus erectile dysfunction because of nerve endings, I think those options are really all kind of the same in terms of what you think is the best option for you. There aren't really any good studies that saying improving the blood flow with any type of surgical intervention or stenting or things like that are helpful. That's maybe the space where that wave therapy may be helpful to help with blockage from blood flow. But again, that's not FDA approved.
Thank you. Now, what might cause pain with ejaculation?
Pain with ejaculation with an implant or with just in general?
Just in general, I think.
Okay. Lots of things can cause pain with ejaculation. Some of it are nerve related, some of it can be muscle tone related, and sometimes it can be infectious. Definitely something that requires usually a physical exam to really see what's going on in terms of muscle tone. We usually check urinary check for urinary tract infections to make sure there's not a UTI causing discomfort. Checking or really taking a history of any nerve medications that you're taking, be it antidepressants or other type of medication that can affect ejaculation. Can all affect that.
Now, on the note of ejaculation, when a man has an implant, do they ejaculate normal semen? They asked, or if it's saline from the reservoir.
Yeah, so the penile implant does not affect urination and does not affect the ejaculatory process. And so you should ejaculate this the same way that you already do. Now, that said, a lot of my patients that I see for penile implant placement either had their prostate removed. Removal of your prostate will stop you from being able to make ejaculate. And for that reason, you won't ejaculate. Also, many diabetic men don't ejaculate well because of nerve issues. And so the implant won't restore ejaculation for those guys. So if you're able to ejaculate before your surgery, you should be able to afterwards, but it usually won't restore a lost ability to ejaculate. And then maybe as a caveat to what you were asking about the implant itself, when we do the implant surgery, that fluid is in a closed system. The fluid just goes back and forth from the reservoir into the penis and then from the penis back into the reservoir. It shouldn't leak out. If the fluid's leaking out of the reservoir, there's a problem and we need to do a surgery like Cliff mentioned to replace or give a new implant. But the device really should just shift the fluid back and forth from the penis back into the reservoir, controlled by the pump in the scrotum.
So for patients who are on statins and other medication, how might they be able to tell if these medications are causing their ED?
So statins usually don't cause erectile dysfunction. Sometimes blood pressure medication can. I think that the only really way to find out is maybe talking to your primary care doctor or your cardiologist or the person that is prescribing those medicines to see if it's safe to try an alternative medication. It's a tough spot because you need the blood pressure medication in order to keep your blood pressure low, because if your blood pressure goes too high, if you're hypertensive, that can also cause erectile dysfunction. So it's definitely something that you should do in consultation with the prescribing doctor to decide if you were to stop one blood pressure medicine, which may have a higher chance of causing erectile dysfunction, that you switch it or have the other lifestyle changes in order to lower your blood pressure, including exercise and weight loss, things like that, in order to keep your blood pressure low.
Yeah. Now, there's a lot of late night infomercials for treatment options for erectile dysfunction and medications to treat ED.
Hold on.
Are these medications the same that somebody would get from a local pharmacy?
Sorry, the housekeeper came in, so I apologize. The medicines that you see on those late night commercials and such, they are not the same as you would get with a prescription. Those are non-prescription medicines. So things like Viagra and Cialis and things like that, you usually can only get through a prescription. Those prescriptions can be provided by a provider like me, a urologist. Often primary care doctors will write for prescriptions like that. There are other avenues of getting medications like Roman or Hims are options for getting prescriptions, but those are where you consult with a physician online and they write for those prescriptions. In my experience, they charge a fair amount of money for those medicines, and we sell Viagra and Cialis through our office. And if you want to get those in that way, they would be significantly cheaper than buying them online.
So on the money side of things and coverage side, why would Medicare cover an implant and not Viagra?
Got to ask your senator.
That's-
I don't know. That's interesting. You know, I find that interesting as well. But Medicare does cover a penile implant, does not usually cover pills. The one nice thing is that we usually do have avenues to get Viagra and Cialis, at least the generic types, at a pretty reasonable price for our patients at this time. But yeah, that's the answer. Is I'm not sure who approved that to be approved by Medicare, but I think it is, and I think it's a really important thing because I think especially in my patients that end up getting a penile implant, they're very happy that they had it done. And penile implant surgery, if you're paying cash for it, it can be rather expensive and probably cost prohibitive to lots of patients. And I'm very happy that it's covered by most insurances.
We get some timing questions. How long can the effects, I'm guessing the active effects of Viagra or Cialis last? I'm guessing those are different.
So Viagra usually lasts in the body it takes about an hour to kick in and stays in the system for about 4 to 6 hours. Cialis takes more like an hour or two to kick in and usually stays in the system for 36 hours, so for a day and a half.
Now, how long does a penile implant surgery take?
So the surgery itself, I usually tell my patients that they to think of their penile implant surgery is about 3 hours, but that the surgery itself takes about an hour and a half. A lot of that is when you have your surgery, we put you to sleep, we shave you, we wash you, we do lots of things in order to prep you and get you ready for the surgery, which takes almost an hour before we actually make any incisions or any part of the surgery. Then the surgery itself takes about an hour to 2 hours, depending on the issue and the complexity and what else is going on. And then another hour really to wake up from the procedure, get to the recovery room until you see your loved one. So, if you ask me, I would say penile implant surgery takes about an hour. But, when I'm telling you about to get ready for a penile implant surgery, I tell the patient's partner it'll be about a 3-hour operation because that's how long they'll be away from.
Thank you. Just a couple more questions here. Haven't seen this one before. How common is skin splitting on the penis when using Viagra?
Skin splitting?
Skin splitting, like SKIN.
Oh, skin splitting.
Yep.
Yeah, that can happen. That's usually because of other issues with the skin itself. Oftentimes I'll see patients that either haven't had an erection in a very long time or haven't had a full erection in a long time. And then when they take Viagra or Cialis or they get a penile implant, they get a much better erection than they had before. The skin hasn't been stretched in that degree. And so you can get skin splitting or irritation to the skin because of that. I also see that in some of my patients that, are uncircumcised and then they take Viagra. Similar idea that the skin from the uncircumcised skin hasn't stretched that much and can get splitting for that reason. So it's more that the skin itself just hasn't been stretched or is predisposed to be irritated. If you have dry skin, if you have diabetes, if you have cirrhosis, you can have other issues where the skin can be more irritable, and that full erection really just stretches it more than it's been used to.
Thank you. Now, any exercises that are out there that can help with erectile dysfunction?
There's really not any exercises that are out there to help, alleviate erectile dysfunction. I do have some of my patients that will use the vacuum erection device that I mentioned before, sometimes without even putting that ring on, just to stretch the penis. I tend to use that in men that had some issue or traumatic issue, often prostate cancer treatment. So after their prostatectomy, if they use a vacuum device on a regular basis in order to stretch the penis, allows the penis to become more engorged and hopefully will preserve length and size of the erection as the nerves recover after prostate surgery.
Thank you. And I lied before, so these are the last two questions, I promise.
It's all right.
So somebody broke their back and has nerve damage, and nerves to the penis were obstructed. What treatments are available to this person? And can you do anything to address that problem?
So you said the patient that had a significant spinal cord injury and now has erectile dysfunction?
Broke my back and nerves to the penis were obstructed. What treatment is done to address the problem?
Unfortunately, in that situation, it's really making sure you do everything in your power to, see the right neurosurgeon or orthopedic surgeon, whoever does, the back surgery. And the hope would be fixing the nerves, at the area of injury will fix the downward stream of that information of those nerves. If you have persistent erectile dysfunction after that, and after you feel that your neurosurgeon or whoever's taking care of your back injury has really done everything you can, at that point, injection therapy, vacuum device, or penile implant surgery are all options for you. But like I said, I tried to exhaust all of the neurologic treatments for your injury first, and then go down the pathway of those other options. Especially a penile implant, I tend to wait to do a penile implant until I know that everything else has been exhausted. But in the short term, vacuum device and injection therapy could be used.
Now, last question here.
Okay.
If someone wants to get a hold of you, what's the best way to do that?
That's a great question. So my understanding is that you're going to email out to anyone that logged in or even that signed up for the webinar. Should get an email with contact information for our office and how to get in. You can also call the office. Our office is Urology of St. Louis. We have a centralized call center. So if you are saying that you had a webinar with me, that you're interested in an appointment with me, I would start off by saying that that's how you got the information, that you'd like to make an appointment with me or one of my physician assistants, either in St. Louis or in Illinois. I do have a new partner that started about 9 months ago now, Dr. Islam, who is great and also did a fellowship in men's health, who also has availability to see patients with erectile dysfunction. And he's a great addition to our group and is doing a very good job seeing patients.
As well as your PA, Mustafa. So you heard it, folks. You will get an email tomorrow with a link to this presentation, should you want to watch it again. Dr. Goldenberg's phone number. Again, mention that you saw this webinar, and you'll have access to some appointment slots there and a link to Dr. Goldenberg's provider page. I really want to thank Dr. Goldenberg for all the information that he shared tonight, taking all this time with you, and Cliff for sharing his story and all this information. There's no two people that do it better. So thank you both very much, and thank everyone for attending.
Thank you all for tuning in. I appreciate your log in and taking the time. Have a good evening.
Have a good evening, everyone.
This concludes tonight's Men's Health webinar. Good night.